Welcome to the day two of Radiology and Imaging Summit. We will now have a science presentation by Dr. Parang Sangvi, consultant radiologist, Jankaria Imaging Center. Earlier, we had a panel discussion on quality. Now, we are moving on to the scientific presentation. It's a very important topic which Dr. Sangvi is going to present here. It's about CT imaging in COVID-19 and what a radiologist should know. So, over to Dr. Parang here. Dr. Parang.
Thank you so much. Is my PPT visible? And am I audible?
Yes, yes.
Okay.
You
Good
can take
afternoon,
it full
everyone.
screen. Yeah.
Yes, fine now. Okay. Good afternoon, everyone. First of all, I would like to thank all the organizers for having me here to speak on such an important topic, which is CT imaging in COVID-19 and what a radiologist should know. So, as we all are aware, we are in a pandemic situation, and we know that this is going to stay for another at least few more months. And earlier, like the role of radiology was very minimal. Then suddenly, a paper from Wuhan came which said that CT is actually better than RT-PCR, and of course, it received some criticism. And but pretty much today, we are in the situation where CT does play a very important role. Almost every patient known or suspected to have COVID are going to get a CT scan done. And it is very important to know all the findings that will help us to conclusively tell whether this is COVID or not. Because as the earlier issue was to pick up how to pick up these lesions, now we are at the other side where there are too many false positive. Almost every ground glass attenuation, people are calling it COVID. So let's see over a period of next 40 to 45 minutes that how we should be more specific in this and how to avoid those false positive in our CT scan. And then, of course, eventually the RT-PCR is going to be the gold standard. So over a period of next 40 to 45 minutes, I'm going to talk about first the HRCT manifestations, because I think this is very important. What we have seen is that while the lesions are very well picked up, the interpretation might be a challenge sometimes. So what is what? When to call a ground glass, when to call a reticular opacities, and especially now when we are almost 6 to 7 months down the line of COVID follow-ups, we are going to get follow-ups which the clinician's question would be whether there is a fibrosis or not. And again, there is an issue that whenever we see reticulation, we tend to call it a interstitial fibrosis, which is not true. So again, that's why we need to know that what are the specific signs for this. Then we'll see the specific signs on CT for COVID-19 itself that will help us enable to accurately diagnose COVID-19. Then of course, there are going to be mimics and differentials. So then we'll see them and we'll see how to avoid them. Next, the CORADs and CT severity score, which are specifically developed for COVID-19. First, CORADs to help us know that what is our confidence level to tell this is COVID or not, and CT severity score that help us prognosticate the patient. And then finally, follow up with fibrosis and some quantification software that we have, and some incidental and interesting cases to end this session. So let's see the HRCT manifestation. So this is the ground glass. Now we all are very familiar with this, but again, there are some issues with this. So ground glass, when do you call it? It is basically increased density in the lung, which is not obscuring this vascular markings. So this is the time when you call it a ground glass and not consolidation. But what happens if this ground glass is accompanied by reticular opacities? So this is the example where you see both of this. There is a ground glass attenuation with reticular opacities that tells us this is what we are now very much familiar with, crazy paving pattern. So this is what a typical crazy paving pattern looks like. So what you see here is the diffuse ground glass attenuation in the lungs superimpose this smooth septal thickening. So this combination is crazy paving and another very important sign in COVID-19. Next is the consolidation. Now, this is a very specific type of consolidation, as we all know. But what consolidation and ground glass differentiating point is that in this case, you will not see those vascular markings; they are obscured. So this is when you call it a consolidation. And again, we'll see the specific signs which is about this consolidation, which helps us pick up COVID-19 as well. So these were about what are the signs we see at presentation. On follow-ups, when we look at it, we should look at the septal thickening or what are called as reticular opacities, but it is different. So first is the septal thickening or the interlobular interstitial thickening, which basically means that the septa between the two lobules are thickened. So that's why now you are able to see this secondary pulmonary lobule so well. because they are otherwise invisible. But because of this septal thickening, now you can see the secondary pulmonary lobule so well. And but within the lobule, you do not see any interstitial thickening. So this is what you call as a septal thickening or the interlobular interstitial thickening. Against this, where you see that the septal thickening or the intralobular interstitial thickening, where there is architectural distortion, now you are no longer able to see this secondary pulmonary lobule. And this is the fibrosis or the interstitial thickening within the lobule. So this against this is a septal thickening which is interlobular, and this is intralobular, or what we sometimes even refer to as reticular opacities. Next is honeycombing. We are used to see this in our typical UIP cases, which honeycombing is nothing but multiple cysts stacked upon one upon the other with shared walls. And this is going to be a very specific sign, though it is not yet so common to see in COVID cases, but maybe few months down the line when more follow-ups comes, if we start seeing this is one such sign which is irreversible and that can conclusively we can label as a fibrosis. Another important sign is traction bronchiectasis. So when we see this reticular opacities along with this traction bronchiectasis, then also it is a sign of irreversibility, and this we can then label as fibrosis. But remember, some form of tubular bronchiectasis are always present along with ground glass also. So again, just looking at this directly may not help us to call it fibrosis upfront, especially on follow-up if this is increasing or there are new reticulation accompanied by this traction bronchiectasis, then we are more sure. But all in all, these are the three patterns which we are looking for to call anything as a fibrosis on follow-up, otherwise not. But still, if the follow-up is less than 1 month, usually we rely at least 3 months on a follow-up to start calling anything fibrosis, because this is a new disease and pretty much any type of lesion can resolve over a period of time, and we are still not sure that what is exactly going to happen. And as against this ground glass attenuation is again used to be always a problem because this is a very non-specific sign. There are many diseases which present with this ground glass attenuation. And even before this, we used to rely on history that the same pattern, if the patient is a known CTD, we will call it as a NSIP. If this patient present acutely on a ventilator, sudden deterioration, this is going to be the acute interstitial pneumonia or edema. If the patient has a subacute presentation with this kind of picture and there is history of allergen exposure, we'll call this hypersensitivity pneumonitis. If the same image was seen in a patient who is a smoker, we'll call it a desquamative interstitial pneumonia. And if this patient has a history of HIV, we would also think of pneumocystis carinii pneumonia. So already this ground glass is a non-specific sign which has a number of differential pretty much decided by the history. And just for the fun sake, this if the patient present in 2020, we are going to call everything like this as a COVID, but it is not. And over a period of next 30 minutes, we are going to see how to characterize this ground glass and how to look for the other signs that help us specifically tell whether this can be COVID or not. So what are the specific signs on CT? Number one is ground glass attenuation. And remember, the keyword is perivascular, because as more and more understanding of this COVID pathogenesis is being developed, we know that the basic problem is angiopathy. It leads to angiopathy, and that's why all the lesions are seen around the vessels, which are prominent also. And as they progress, they may confluent to larger lesion like this, which are very well seen in the reconstruction as well. So this is our first sign, the ground glass with perivascular distribution bilaterally, which is a very typical sign in COVID-19. But this ground glass attenuation can present in different manner. So just now we saw if it is accompanied by this reticular opacity superimposed on this ground glass attenuation, we tend to see this appearance which is called as a crazy paving pattern. So this is what we can see in this reconstruction images also. So the same ground glass, if overlapped by septal thickening, we will see this crazy paving, another specific sign for COVID-19. Another example of COVID-19 which shows this crazy paving beautifully, this ground glass attenuation which has a superimposed septal thickening as well. And all this time you can also observe that the vessels are quite prominent within them. Next comes consolidation. So typically it is said that in a more severe cases, or the patient who are not doing so well may likely to show this consolidation type of pattern, which as we saw earlier, these are increased density with obscured vascular markings. So these are the consolidation which we typically see in a peripheral distribution predominantly in both the lungs, and that help us tell this can be COVID as well. Again, consolidation can have a different signs like halo or the reverse halo sign, which is called as atoll sign, as seen in this is otherwise showing a ground glass attenuation, but there are denser consolidation areas here, which are surrounded by ground glass attenuation, which are forming a ground glass halo. Or sometimes you can have a reverse halo. That is, the ground glass is in the center and it is surrounded by the denser consolidation, as seen in these two examples. Again, these are also signs of COVID-19. But many times we see mixed patterns. So as in this patient, in the upper lobes, we see this reverse halo sign with the ground glass attenuation. In the lower lobes, we see this denser consolidation and even subpleural band-like appearance. Another patient which shows more florid involvement, where there are multiple areas of ground glass attenuation along with consolidation, with some showing crazy paving pattern as well. So all these signs can present in a various combination in COVID-19 cases. Now, how to pick up this ground glass attenuation? Now, the examples that we saw so far are the very typical and a florid cases. But in our country, especially many patients just get the CT scan done even if they suspect there may be COVID. Even the patients who are not symptomatic but have a exposure or the contact with COVID patient or who are just started becoming symptomatic mildly may get a CT scan done upfront. And in these cases, we tend to see such mild lesions like this. We see only few such ground glass areas in the entire lungs. And if we were to see the scan in our HRCT window images, we might miss them. So the MINIP images really help in this picking up because it then a kind of homogeneous appearance of the rest of the lungs is seen on which this ground glass attenuation will be highlighted better. Then retrospectively you can see this, but as you can see there are multiple areas which looks like this, and then you might not be sure. But then this MINIP really helps us pick up this perivascular images. So basically what we have seen is the COVID leads to this organizing pneumonia pattern. The various combination of ground glass attenuation with the crazy paving or the consolidation is showing this perivascular central and peripheral distribution, which we are used to familiar to see this before 2020 in a typical organizing pneumonia cases. Next comes the sign which is very important in follow-ups usually is the reticulation. But it is not always that it comes up later in the disease. Sometimes we have seen even at presentation, this type of reticulation, as we discussed earlier, like septal thickening like appearance is seen here. But usually they are seen on the resolving cases. And if we were to see this image directly, then we might think of NSIP pattern. But again, the history becomes really important. The patient becoming recently symptomatic has a history of probably COVID positive in recent past and without any other CTD or other known cases, which help us tell that this can be COVID. Next, another interesting sign is very commonly seen in COVID is the bands. Earlier, it used to be thought as this as a areas of fibrosis or maybe resolving pneumonia, but now we know that these bands are often seen at the time of presentation as well. And even with more and more knowledge is developing that how the COVID is manifesting in lungs, and with the help of dual energy maps with the perfusion analysis studies, we have now realized that these are nothing but the edematous lung overlying the area of hypoperfusion. Otherwise, we used to see this atelectatic being so commonly along with pleural effusions where there is subsegment atelectasis in underlying lungs. This typically occurs in COVID patients in at the time of presentation, but they are not to be mixed up or confused as a sign of fibrosis. And this can also be very well be reversible as we are going to see some examples in coming sessions. Another interesting sign that came up, especially in the severe sick patients who are hospitalized and who are not doing so well, they have a florid involvement. Almost the entire both the lungs are involved, but typically this upper non-dependent part, anterior parts of the upper lobes are spared. Again, this is not something new. We are used to see this in a patient with ARDS who are otherwise sick, bedridden, and this because of this gravity effect and other pathophysiology that happens. This is also another sign that we have seen in COVID where there is a anterior parts spared. So, having understood these signs which are specific to COVID-19, we can pretty much reliably diagnose COVID-19 on CT scan on most of the instances. But still, as we discuss this ground glass and this different sign or the pattern or organizing pneumonia is not a specific sign, we tend to have mimics and the differentials that we need to keep in mind. Because basically, all the pattern of COVID-19 are just revolving around these findings, which are ground glass, crazy paving, organizing pneumonia, and in severe cases, ARDS like pattern. So this was our actually the first case. This came up in March 2020 when initially we just have started seeing some cases in India. There were some reports of positive cases in Pune, and this patient had actually come to Mumbai from Pune, and we just saw this CT images and we were really scared that we have seen the COVID probably. The lockdown had also not happened by that time. But now in retrospect, we can clearly see that these lesions are different. These are the dense consolidation which are bronchocentric and covering the large parts of the lobes. And even in lower lobes, we tend to see this type of infectious bronchiolitis type picture, which we do not see in COVID-19. So this patient was also not confirmed to be COVID-19 and was treated as a H1N1, and he did really well. Another COVID mimic is of course the cryptogenic organizing pneumonia. Now, this is an example of 2018. So, of course, there was no COVID at that time. And we see this typical consolidation with reverse ground glass attenuation, where you see this ground glass surrounded by condensed consolidation. And these are the, this patient did not have any etiology, so we labeled it as a cryptogenic organizing pneumonia. So, again, in current situation, we were to see this picture directly, we might call it COVID, but then other workup is very important along with history. Another example is this eosinophilic pneumonia. Again, just now we saw this band-like appearance in COVID, very characteristic in seen in COVID, but we have to remember this differential of eosinophilic pneumonia as well. This is an old case of 2016 where the patient was proven to be eosinophilic pneumonia, shows a very similar pattern, band-like consolidation in the subpleural region bilaterally with lower lobe predominance. But the most important, as I see right now, the issue is the all the patients who were not getting the follow-up for the ILD during the lockdown for over a period of 3 to 4 months, I haven't started coming for their regular follow-up for the ILD. And then if we see this ground glass attenuation superimposed, we tend to call it COVID. As seen in this example, this patient was a RA, known RA-related ILD with typical UIP pattern, as you can see this honeycombing with basal predominance. And this follow-ups can show this new diffuse ground glass attenuation. Again, because of the high suspicion of COVID-19 in this current pandemic situation, it was labeled to be like that. But this patient had nothing but an acute exacerbation, and he did really well immediately after a short course of steroids. IgG4 disease is another pattern which shows another disease which shows similar pattern like seen in this, which see this perivascular with central and peripheral distribution nodules and consolidation like lesion. And again, here the clinical workup will be very important. Otherwise, these lesions can really mimic like COVID. This patient had was on chemotherapy and suddenly deteriorated. And again, the history of a known malignancy on chemotherapy with the temporal changes as expected as per the chemotherapy-related lung toxicity, then we can call this as a chemotherapy-related lung toxicity and not to be mixed up with COVID-19. Another example, this patient had presented in emergency setting. This X-ray was done, and immediately looking at this X-ray, the patient was called as COVID, isolated. Nobody was ready to admit him for immediate emergency. This was early in the disease, in the lockdown period when everybody was not ready to admit the COVID patient. And just looking at this X-ray, the patient had a really hard time finding a medical help. But eventually, he got a CT scan done based on this, and he is a known case of HIV. And we see this is also another type of appearance where we see this bronchocentric diffuse lesions with perihilar distribution. And you see this typical cystic like lesions also, which we know that in the known case of HIV, this can be PCP. It is more likely to be PCP than anything else. And this was subsequently proven. And this is not COVID. The typical crazy paving pattern which we are used to see, and we know this pattern basically from this disease, what is called as a primary pulmonary alveolar proteinosis. And this is also an old example of PEP. And this is where you see this diffuse ground glass attenuation throughout the lung parenchyma bilaterally with superimposed this septal thickening, which is nothing but a crazy paving pattern. And post lavage, the patient, you can see immediate resolution of most of the lesions. And this is nothing but PAP. Another important differential in current situation is the pulmonary edema. So remember, whenever you see pleural effusions bilateral, this is not a specific sign of COVID-19. And even for that matter, otherwise also, whenever we see bilateral pleural effusion, the first thing we need to rule out is the pulmonary edema. So when you see this type of bilateral pleural effusions, then the lesions in the lung, which shows the ground glass with this typical smooth septal thickening, which shows this perihilar or the batwing appearance, and then you also see the cardiac status, and you can see there is a mitral calcification, there is LA dilatation. You know that this patient has a cardiac failure, and this is pulmonary edema, and this ground glass lesions we are not going to call as a COVID-19. Another important differential is to remember in the patient who have TB and who comes with hemoptysis. So here the history of hemoptysis is important. So this patient presented because of sudden bouts of hemoptysis over a period of 2-3 days, and of course the cough had also exaggerated because of this. And again, the symptom, looking at the symptomology, the patient was otherwise suspected to have a COVID now. And the background post-fibrosis lesion, post-infectious fibrosis was same as the earlier scan. This ground glass attenuation was a new, but then we knew that with the history of hemoptysis, this can very well be intraalveolar blood, and the patient was followed up, did even a bronchial artery embolization, and this was then resolved, and this was intraalveolar blood because of hemoptysis and not COVID-19. So, is this confusing? Is this ground glass not really helping us? Even all the specific signs like reverse ground glass halo, atoll sign, the crazy paving, nothing is helping us. Then what is it? There is one specific sign of COVID-19 which sets it apart from the rest of these ground glass lesions, which is this is the angiopathy. So what happens in angiopathy is when we see this type of lesions, this is a reverse ground glass example, you see these proximal vessels which are dilated. It can be even intralesional dilatation or the proximal vessel dilatation. So we know that this lesion is also having a some component of angiopathy. We do not see this otherwise. In the other infection consolidation, we do not see such large caliber vessel proximal or within the lesion. So this is one specific sign. If we see, then we know that we are dealing with angiopathy and in this case COVID-19. Another pattern that we see is the large subpleural vessel. Usually the vessel stops some margin before the pleura. But here you can see such large vessels coursing all the way up to the pleura, and even this maximum intensity projection, the MIP reconstruction also help us see that this subpleural lesion is also showing such large caliber vessels. So this is also a sign of angiopathy and very commonly seen in COVID-19. And of course, this literature describes very fancy science like this paper that came in medical journal in recently, which said this Dandelion sign, which is nothing but when you see this vessel surrounding by this ground glass attenuation, or this may also resemble a feather-like appearance because there are multiple vessels surrounding which you see this ground glass. So these are nothing but a fancy signs, but basically it means the same thing that there is a prominent vessel or a angiopathy. But a specific sign that has recently now been described is the vascular tree bud. In this recent paper by Patel et al., they showed this similar like what we are used to see in a tuberculosis patient, the tree bud appearance, but it is a bronchiolar pattern and this is a vascular. You see this vessel will show this tree bud or a branching nodular like appearance. And this is also another sign of angiopathy. But what they saw is that they saw this sign pretty much in the patients who are not doing well, who are very sick, hospitalized, and they found that when you see this sign, the patient tend to have a more longer hospital stay or a bad or a more adverse outcome than the rest of the patient. But we are seeing this even in this mild cases like this with mild involvement. Symptomatically also the patient is not that bad. And this can show this vessel which this branching like appearance or a train bud appearance. Another sign that is recently described is this target sign. So what you see here is this small central vessel which is surrounded by this ground glass attenuation, and then there is a relatively spared lung, and then surrounding it you again see this ground glass attenuation. So this is nothing but this perivascular inflammation along with this organizing pneumonia, which are then seen together as a target sign like this, where you see this central blood vessel, then this perivascular inflammation, then surrounding it will be the normal lung or the relatively spared lung, and then the ground glass halo. So this is also another sign which is recently described, which is the target or the double halo sign. So these were about still the plain CT. Now, really, if you see the more and more literature is now coming with the use of dual energy CT scan. Because of we have now know there is a angiopathy, there are tend to be a perfusion changes in the lungs, which can only be picked up with dual energy perfusion maps. So this is now all the recent articles over a period of like 2-3 months, they have started looking at it with DECT perfusion maps. So what they found out is these lesions, which are very typical of COVID, actually show hypoperfusion. So if you see this normal lung parenchyma, these are all hypoperfuse area where there is a ground glass lesion. These are really well seen here also. And immediate surrounding it, the lung parenchyma shows hyperemia or hyperperfusion. So as you can see here, this is a hypoperfuse area surrounded by a hyperperfusion or a hyperemia, and this is then the normal perfusion. So there is definitely a angiopathy here, which leads to this differential perfusion. Another paper by Outkirk in Radiology also showed similar findings where they found hypoperfusion surrounded by hyperemia. Then came this paper by Santa Marina, which also showed this similar ground glass lesion, which shows hypoperfusion and surrounding hyperemia. But they also found there are large hypoperfuse area in the surrounding lung parenchyma as well. One more paper by Oudkirk later also showed this similar finding, where they saw this hypoperfusion in the areas involved and surrounding hyperemia margin. Another recent paper which then just compared in general what happens to the small pulmonary blood vessel status. So what they found is in healthy patients we see this such large good density of pulmonary vessels. The COVID-19 patient in general have this diffuse abnormality of angiopathy, which leads to this severe diffuse uh, small pulmonary blood vessel, which are quite less in number and less in size as compared to the normal patients. So not just the lesion specific sign, even in general, the entire lung has some component of angiopathy, which leads to this reduction in small pulmonary blood vessel. And finally, last week, this came where they quantitatively try to measure the lung perfusion or the lung enhancement by looking at the DCT perfusion map with iodine density. And they found that overall decreased lung enhancement in the entire lung when measured collectively that suggests vasculopathy and correlates with RV dysfunction and adverse outcomes. So this is what the pathogenesis is now believed to be, that basically it starts as a viral endothelial insult or a viral endothelitis with endothelial injury, then progress to in situ pulmonary thrombosis, and these are the microthrombi which may not be visible on pulmonary angio, but eventually they progress, the thrombosis progress with macrophage activation, and that is the time patients start deteriorating and all your markers start elevating. The D dimer, the interleukin, LDH, ferritin also helps with pick up this what is labeled as earlier as the cytokine storm. And then as it further progresses, the thrombosis can extend further, and then it may be visible even on pulmonary angio where the large vessels are involved, and then ultimately it leads to diffuse alveolar damage where the patient really deteriorates suddenly with severe hypoxemia and hemodynamic compromise. So these are our example. We also try to do this with DCD perfusion maps, and we also found similar lesion where there are the lesion with ground-glass attenuation characteristically show this areas of perfusion defects. But we also found, just like the previous paper, that even the adjacent lung, which are looking otherwise normal on our standard CT scan, also shows this hypoperfusion, with surrounding this hyperperfuse or a high areas of hyperemia, which is characteristically replicated as we saw in the papers earlier. So this is COVID-19 does leads to this vasculopathy, which leads to this perfusion defect, and then the immediate adjacent surrounding lung shows this hyperemia. Another example where we saw this pulmonary, there was no pulmonary thrombosis, but these lesions are appearing as the areas of perfusion defects in DECT perfusion maps. You can see bilaterally. So what is pulmonary thrombosis? Remember, this is not thromboembolism, and it is quite a frequent phenomenon. One study found that in admitted patients with sudden deterioration, as much as 90.2% segmental and 61% segmental arteries are affected by consolidation pattern will show this pulmonary thrombosis, which are microthrombi. But in this case, it is due to severe lung inflammation and a hypercoagulable state, and not thromboembolism, which we see otherwise in a DVT patient. So another our example, this patient with known UIP suddenly deteriorated, and on follow-up we saw this ground glass attenuation, which can again be confusing with acute exacerbation. But along with this, the pulmonary angio shows this thrombus, which is present bilaterally, more marked on the right side. You can see both the upper and lower lobe branches shows this thrombi, and the perfusion maps were even more alarming. You can see there are large areas of perfusion defects bilaterally. Almost most of the lung are not showing adequate perfusion, and only the remaining part which is showing perfusion, which shows this hyperemia. You can see this more yellow color is towards more hyperperfused regions. So this was also replicated well, and this patient though shows this extensive perfusion defect despite showing no significant disease on CT scan, and the patient really did not do well, and the patient actually expired after 2 days. Another example of COVID-19 where we saw this typical target sign that we just discussed with this halo appearance, and this patient also showed pulmonary thrombi on the pulmonary angio, and the perfusion map showed perfusion defects. So with this additional information also we can try and prognosticate patient that this patient are tend to do not so well. What happens in pulmonary angiography? So on pulmonary angiography, if we have done collectively, we can see all these signs together, which are on plain CT and the contrast CT, CTPA, what we have discussed in last 10 minutes. On plain CT, we can see this prominent intralesional and proximal vessels, the Dandelion and feathery sign that we discussed, the subpleural prominent vessels, the vascular tree in bud, target, and the double halo sign. These are all signs which tells us that there is angiopathy in addition to the infection or the inflammation. And the contrast study, if we have done CTPA, will show pulmonary thrombosis if present. But the DECT perfusion maps are really helpful. They help us see this hyperemic halo sign, the perfusion defects within the lesions, and the overall reduced blood flow in the entire lungs. So if we have done CTPA, though it is not indicated not to be done in all the patients, but if this is done, then do look for this perfusion sign, which will help us prognosticate this patient better. So having understood this, how do we report? So cohorts then initially came and it got a wide acceptance immediately. It is nothing but it tells us the likelihood that the radiologists feel that this is going to be COVID. So if we say cohorts 1, it is highly unlikely. 3 will be indeterminate, and the 4 and 5 will be probable or high likely. And when there is already a known RT-PCR positive status, it will be 6. So this is one such example where we don't see significant lesion, just some fibrosis here. So this will be our cohorts 1, where we do not suspect COVID at all. This is another example where we see this branching tree in bird sign, and we know this is infectious bronchiolitis, so highly unlikely for COVID. So this will be cohorts 2. Then comes cohort 3, where there will be still indeterminate, and this patient we cannot directly label COVID on the CT scan. And these are the signs where we see some ground glass in the periphery, but otherwise normal lung. And this is the typical example of COVID lesion, but just because it is present unilaterally, the left lung is completely normal, the literature tells it to be labeled as a cohorts 4. But if you see this large vessel forcing and proximal, we know that if there is a angiopathy component also added to it, we can confidently diagnose this as a COVID. And finally, this cohorts 5, which we are all very familiar to see this bilateral ground glass at perivascular opacities with central and peripheral distribution. But before that, the RSNA expert consensus statement that had come earlier in March, and that really is a self-explanatory and a better terminology than just numbering it, because it then asks you to just divide whether you say this is a typical, indeterminate, or a atypical appearance, or completely negative for pneumonia itself. So the same thing, this will call it as a directly negative scan. This will be atypical because we know this is something else. This will be indeterminate because this can go either way. But this both will become typical because we know this is going to be COVID-19. So this terminology also helps us convey the message that how confident are you as a radiologist to call this COVID-19. Next important part is the CT severity score, because once the findings are picked up or the patient is diagnosed to be COVID, the clinical picture and how the patient is going to behave is very much decided by CT severity score as well. And there are multiple studies which have proven now that CT severity score, especially over 18, more than 16 or more than 18, really leads to a adverse outcome. So this 5 lobes uh, CT severity score is very helpful and very simple to use, because all you have to do is measure in each of the 5 lobes that are present in both the lungs. If you feel, and this is just eyeballing, there is no software. If you see less than 5% or a very subtle involvement, we'll call this as a score 1. 5 to 25 will be 2, 26 to 49 will be 3, 50 to 75 will be 4, and more than 75 will be 5. For each lobe, we have to give the score from 0 to 5, and then total, if the total is in ranging, can range from 0 to 25, as we can have maximum score of 5 in every lobe. And then if the score is more than 16 or sometime even 18 taken as a cutoff, then we know there's a severe involvement. So let's see how to implement this. Now remember, when you try to score this, do not just see on the axial images, try to correlate along with it on the coronal and sagittal reconstruction as well. Because what might seem to be a big lesion on the axial scan might not be such strong, such large on the coronal or a sagittal scan. So if you were to see this, this is the upper lobe, which is showing, say, roughly about 5 to 25% involvement. The right middle lobe also seems to be like 5 to 25% involvement. So we'll score them 2, 2. The right lower lobe looks more than at least 25%, but less than 50%. So we'll call this as a 3. Left upper lobe, again, if you see here, there is a less than 25% involvement. Then we'll score this as a 2. And left lower lobe looks most significant. Large part of it is involved. Looks more than 50%, but less than 75. So this will be 4. And then when you add them, you know it is 13 by 25. So we're going to label this as a moderate disease. Another model that was as 20 segments, this is a bit complicated because then you have to see in every segment. And just like the normal anatomy of lobe is very easy because there are fissures separating them, the calling segments will be difficult. You need to be very well aware with the segments, all the segments of the lung, the various segments within each lobe, and then you can label them as whether there is a 0, no involvement, less than 50% involvement, then we'll score it as a 1, or more than 50%, there will be score 2. So you can have 0, 1, 2 in each of the 10 segments on either side, so total 20 segments. So the maximum score will be 40. But this is a little tedious, and if you are in a busy practice where you are reporting more than 10-15 cases a day, this is going to be a difficult. So the 5 lobe model is more acceptable. And there are recent various severity score which is tried to based on the consolidation with the ground glass, because this is making more sense, because we know that a patient with consolidation rather than ground glass with same amount of involvement are likely to not do so well in follow-up and may have a adverse outcome. So when the patient comes for follow-ups, the all question the clinician has is whether there is a residual fibrosis or not. There is bound to be improvement on most of the occasion, but what are the residual lesions? And it might be still little early to call anything on as a fibrosis, and over a period of next few months when we'll see more and more of follow-ups and we'll see how these lesions, even the residual reticular opacities are behaving, we'll be in a more better position to call fibrosis. But as of now, what we have is this quantification software, the caliper that we were already using for ILD, and it was really helpful in even in a routine ILD patient just to see whether there is a progression or not, because it then tells us how much percentage of the lung is involved in total. So this is 76% normal, that means 24% lung is involved. And it also tells under this various parameters that how much is the ground glass, how much is the reticular opacities in both the lungs. And then we can tell that this patient okay has about 21% involvement of ground glass with reticular opacities. And it really helps in follow up, because rather than having a subjective visual impact of whether there is improvement or not, this will give a quantitative or a more objective criteria. When these values are changing, we can be more sure whether there is a progression or not. Another software by Siemens Pneumonia CT is where it highlights the areas of ground glass attenuation and the lesion, and then gives the value in each lung just like this. And even if you know, then Osirix also you can do this Salafi method. And pretty much we have tried with all these methods, and they are showing consistent result. So you can use any one of them which is available, but do try to quantify, as it really helps in prognosticating the patient and even in follow-ups. So let's see few of these examples now. So this was a patient who has the characteristic COVID-19 lesions in both the lungs at presentation, and he came for follow-up after 14 days. He was doing really well, and you can see that this is what we typically most of the time we see this, that the lesions are going away. There is a significant improvement. Only you see some residual ground glass in all the areas that were involved. No reticular opacity. So here we are not in doubt of any fibrosis. Another typical sign which is described is this sign. When we see this type of lesions at the presentation, this typical perivascular ground glass and consolidation, when they resolve, they leave this type of appearance, which is described as a melted sugar-like appearance, or a cotton candy sign, or a tinted sign, because it really resembles something like this melted sugar will look like, or a cotton candy, the thin fibers that it appears to be looking like. And this is the typical temporal evolution which we see in most of our patients, which is a combination of reticular opacities with ground glass. Again, this stage is not enough to call this fibrosis, and we will just describe this as a reticular opacities with ground glass. And over a period of further follow-up, we usually ask for a follow-up after 3 months, because that will be time to tell something confidently. And if this persists or start to develop some new signs that we are going to see in the next examples, then we might be in a better position to call it fibrosis. So this was another patient at 27 August when they presented, got a X-ray done, showed typical this multiple ground glass opacities in bilateral lungs. And this is just in 5 days, in 2nd September, he deteriorated very much. So this was the his follow-up X-ray, which shows this significant progression of all the lesions. Even on radiograph, it can be very well picked up. And he also got the CT scan done. So this CT scan, the images on your right are the first scan, and on the left are the follow-up scans. So you can see the lesions have increased really too much. So this is what happens if you follow up in such a close interval. So it is also said that do not try to image the patient in first 5 days, because you are going to see positive signs, but the prognostication or the quantitative analysis will be not be useful, because the patient is still progressing. So then if you just follow up in 5 days, you might see this more florid appearance, but this might not be the actual progression. Actually, this was the would have been the right time to image the patient and to know the exact burden. Another patient who after a period of 9 days also showed initial, she was a doctor actually, so she had a contact history, and this was the only lesion seen here. So we will call this as a Corax 3 or at max Corax 4, and this was the only lesion. But just after 9 days, the lesion started increasing so much, and now you can see bilateral typical involvement. One more patient who in presentation was moderate involvement, who was doing well otherwise symptomatically, was just asked to do home quarantine. And on a follow-up, while we see this similar melting sugar-like or the melting of the lesion appearance, you can see that earlier the lesion were quite otherwise confluent but otherwise discrete, and you can see normal lung parenchyma in between. But on follow-up, you see this more homogeneous appearance. There are more of the normal lung which is now starting to show lesions. Now we do not know whether this is progression or not. It might be possible that these lesions would have occurred in the interim, and now we see them also as a residual lesions. So again, this is not going to be the sign of progression otherwise. But one thing to keep in mind that when you see such normal lung also start showing lesion, but which also show otherwise the temporal evolution just like your other lesions, we do not call it progression, and again not fibrosis. One more such patient who, if you see at presentation, this is the first scan on 11th August. He had these lesions on the right upper lobe and the lingula. Both of them show this melting sign and this mild reticular opacities at both the places. But in addition, this part which was spared initially now starts showing this similar lesions, similar melting sugar-like appearance. So we know this need not be the progression and might have occurred in the interim, which we are now picking up. But what is the fibrosis? So this is one such sign where you can be confident that there is fibrosis. On presentation, the patient had just standard ground glass lesions in both the lungs. But on follow-up, after 2 months follow-up, the patient started showing this reticular opacities along with this traction fibrosis, traction bronchiectasis, and along with some architectural distortion, which is very well seen bilaterally. So this is the stage when you can tell this is a post-COVID fibrosis. Otherwise, without this sign, traction bronchiectasis, architectural distortion, and if honeycombing we might be seeing in future, then it is difficult to say anything as a fibrosis, and it would be advisable to follow up them for a regular interval at 3 monthly interval. So this patient, when we saw at presentation, just we saw earlier, he had a ground glass predominant involvement. Now has a significant reticular involvement as well. And this caliper analysis does help that initially he had a 40% ground glass and 3% reticulation. Now has a 23% ground glass, so that is improving, but there is an increase in reticulation. So that tells us that the patient is though overall is improving, the total lung involvement is less. There is more of reticulation, and this patient is likely to have interstitial fibrosis. Now let's see some incidental and interesting cases. Now initially when we started picking up this COVID, many of the centers also started scanning chest invariably even if the patient has come for an abdomen or a neck study. And even when we scan abdomen and neck, we tend to cover some part of lung which used to show this lesion. And then we did not know what to do further except just informing the referring physician that look, there is a lesion which looks like COVID and he might either get a PCR done or a dedicated CT. So this was one of our such first patient who was an elderly patient who came for a uretary colic pain for a standard KUB study, and the lower parts of the lung which we had covered clearly shows this typical lesion. And this patient was then turned out to be COVID positive. Incidental finding: the patient was not symptomatic at all for any of the chest symptoms. Another patient on a standard viability scan for MRI who came for this inferior wall infarct had actually shown this on MRI also. You can pick up this consolidation like lesion in both the lungs. And then we, of course, confirmed it with the CT scan also. The lesion mimics it really well. And then you see this consolidation with the perivascular distribution. And this patient also turned out to be COVID positive. Again, was not symptomatic at all. What happens on PET? So PET shows this interesting sign. So this patient was a CA breast, CA colon on a follow-up, and what we saw this characteristic ground glass lesions. The patient was again asymptomatic, but also it shows FDG uptake. So when we see such FDG uptake, we know this is going to be an active stage, and also the patient had this small lymph nodes.
Yeah.
Hello. Yeah, small lymph nodes, which also shows this uptake. So this is also a common finding which we see in PET CT, that the lesions along with the lymph node might show uptake in the active phase. And on follow-up, if you see that reticular opacities in resolution, there will be typically no such significant FDG uptake. Another important sign that we came across last month was this patient, which shows this typical COVID-19 findings, but the upper abdomen shows this large adrenal hemorrhages, and it was also the retroperitoneal hemorrhage, which we immediately informed the clinician about this additional finding. And then we saw the literature at that time. We saw that there are a couple of reports who describe this as a COVID, which is a known association in COVID-19 that can be bilateral adrenal hemorrhage, and this patient might suddenly collapse, which happened with this patient also. The patient actually died the next day. So remember to look for this adrenal hemorrhage also, which might be accompanying. And again, this might be just part of the same vasculopathy or the angiopathy that is happening in the COVID. But when there is adrenal hemorrhage, there will be a chance of sudden collapse and death. Pulmonary hypertension is another sign you should look at. Whenever you see this, measure the pulmonary artery. As seen in this example, the patient with COVID has a severe pulmonary hypertension. Now, another sign is the cavitation, which, if present, we tend to ignore COVID because cavitation does not happen in COVID. But why can't the two coexist? Especially in our country, there might be TB. So this was a patient just because of this cavitation, the patient was not labeled as COVID, but the patient has characteristic typical signs, typical findings in bilateral lung, which is of COVID. On top of it, he has this cavity. So he has a TB superimposed on COVID, but do not rule out COVID just based on this one lesion. One more such example with cavity along with typical COVID findings. Another patient who actually came for the respiratory complaint, he has a severe COVID related changes. But in that, we incidentally we picked up also this mass in the right upper lobe, which then turned out to be carcinoma. Another example which we saw earlier that of course the COVID can coexist with ILD, and the important challenge will be to rule out acute exacerbation and not the COVID in these cases. Another patient with a known silica exposure with the typical signs of silicosis seen on the CT scan with axial calcification lymph nodes and this progressive massive fibrosis with this high density nodules also had these lesions perivascular ground glass, and this patient with silicosis has COVID. Another sign that is a cystic change, if we see, it is also not described in COVID. But this patient is a smoker. He already has an emphysema in the background lungs. So you might see these superimposed lesions of ground glass with this cystic lesion, which are not the cyst related to the lung lesion, but the background emphysema. And this also you should keep in mind that you do not rule out COVID based on this. Another sign that we see is this bubble lucency-like appearance, which we are so familiar to see in the pulmonary thromboembolism infarct cases. So the same appearance can also occur in COVID. And lastly, I would like to end with this example. The patient with severe disease, a patient presented in the emergency setting with severe hypoxemia. The X-ray showed diffuse bilateral lesion, and the CT showed what this will be look like a perfect score of COVID, which is 25 by 25. The patient has a diffuse bilateral lung involvement with more than 75% involvement in every lobe of both the lungs. So this was a 25 score, and the patient was shifted to ICU, and the patient did not do well. So over a period of last 45 to 50 minutes, we tried to look at the CT imaging in COVID-19 with some examples of radiographs as well. We first saw the HRCT manifestation, that what are the signs that you should look for in this patient. Then we saw the specific combination of the signs which are so common in to see in CT scan in COVID-19 patients like crazy paving appearance and reverse groundlets, etc. Then we ruled out the mimics and differential, how to see them and what are the important signs for it. Then we saw about the cohorts and the city severity score, how when you see a case of COVID, how you should approach it and how you should characterize and try to call it and quantify it with a CT severity score. And finally, we saw the follow-ups and when to call it a fibrosis and how to quantify. If you have any kind of software, then try to give some quantitative estimation which will help in follow-up. And then finally, we saw the incidental and the interesting cases that we have seen in our practice in last 5 to 6 months. Thank you so much for your attention.
So we have to, yes.
Yes.
Thank you so much, Dr. Sangvi, for your presentation. That has been really insightful.
Thank you.
Can we just present the certificate? Is there? Thank you, Dr. Parag Sangvi,
Thank
consultant
you.
radiologist, for your time. Thank you so much.
Thank you. Thank you for having
A very good afternoon, everyone. And first of all, I would like to thank you all for giving me this opportunity to speak on this platform. Today, I'll be talking about the impact of COVID-19 pandemic on radiology practice. As we all know, during these 2 days, we have discussed thoroughly about various aspects of how radiology got affected with COVID 19. And also, we saw what were going to be the future outcomes. But my talk, I'll be discussing what practical problems we faced during our practice and what we think will be the short term as well as the long term impact of this particular pandemic. Before we start, I would like to acknowledge the contributions from my colleague Dr. Gauri Ahuja, and I would like to thank all the organizers from ELED Technomedia Limited. And also, I would like to thank Dr. Deepak Patkar sir, my mentor, from whatever I have learned in radiology and beyond. The key points which I'm going to discuss is something about the current scenarios, something about relevant statistics, and then how we played a very critical role during these difficult times. And then what are the short-term impacts, long-term outcome of this pandemic, and key things which we actually learned during this course of time and also in from what we experienced in the past. So as we all know by now that it all started maybe in the later half of 2019, but the WHO declared COVID-19 outbreak as a global health emergency on 30th of January, and on March 11th, it was declared as a global pandemic. These are the stats which I am sure all of us are aware of, and we know that these are changing every minute. And these are the news headlines, and all of us are in a habit now to keep a track of these numbers, and it has become a part of our daily routine to know these after this pandemic has started. The good thing is that the curve is now coming down, but yeah, people are predicting that there is expectant second wave and also third wave at some places. So understanding the short term impact on the radiology workflow, as this pandemic started, there were a lot of concerns about handling these patients, and it took no time to understand that chest radiographs and CT scans of the chest were very, very critical for triaging as well as for staging these patients with COVID-19 infections. So we had our own challenges. We had to ensure continued operations during healthcare emergencies because there were non-COVID emergencies as well, to support the care of these patients who already got infected, and to maintain radiology diagnostic and interventional support for the entirety of the hospitals. Because there was so much of concern that routine patients, non-COVID patients, used to think that they should not come for their MRIs or CT scans because they might be facing COVID infection, as this hospital or this center already has scanned COVID patients. Took no time again that a lot of dynamically changing guidelines were shared over the various internationally renowned and recognized platforms. And even in India, all the radiology societies took the lead and came up with the standard guidelines. There were various challenges, like you have to know what is right and what is wrong in terms of the infodemics. The protocols need a lot of changes, because whether to use a pressure injector in CT scan department or not, whether to give contrast or not, various other things were included. Then the finances incorporated in this particular event, then enterprises versus facilities. There were government laws which were changing, and there were a lot of capping which was going on, a lot of restrictions. And at the same time, continued education and research on this topic. And also, we had chest radiologists talking about what is important and what is not. So the key areas to address is during this difficult time which we faced was to establish emergency management and infection control team, reconfigure the radiology department, measures to provide adequate PP to the radiology personnel. Most importantly, when the X-ray technician used to go for the chest X-rays to COVID wards and ICU, we were really careful about giving them proper PPE devices, because he used to come back to the routine radiology in-house department, and then there were chances of spreading the infection with these PPEs or these fomites. Ensure proper staff training, ensure judicious use of radiology equipments and manpower, streamlining the workflow, promoting and developing remote access to radiology images for tele-interpretation, because this remote access was really important, because not only it was outside the hospital our radiologist can sit and report, but also within the hospital. So supposingly a CT scan was going on in the department, then the resident or the doctor reporting the CT can sit in the MRI department console and report these scans. Create institute organization specific guidelines, and also to control the infodemics. So a lot of steps were taken at every point, and including the key point of entry of the patients onwards to triaging of the patients at the entry, then sending them to the respective accident and emergency channelized non-COVID COVID parts, and then to decide which scan they require. So there was a lot of education, innovation, collaboration, and a lot of new strategies being formed. So we were categorizing, screening, triaging patients not only at the entry gate of the hospital, but also in the radiology department, because various patients, they are just OPD referrals. They did not come to get admitted in Nanavati hospital, but they just came for a scan. So it was our duty to again kind of do a second check when they reach our department, and to understand if they have any risk factor concerning for COVID. This was very early times. The test used to take maybe 24 hours. Everybody was not keen on doing those RT-PCR testing. They just came for routine MRI of knee, shoulder. So they were also not very keen on giving the detailed history. So a lot of confusion, and I'm sure all of us faced this situation. A lot of optimization of the resources was required. Visionary approach from the admin was really important and critical, and they definitely took a lot of steps which helped us to curb the infection spread among the staff, among the patients themselves, and also helped us bring about treatment positive outcome in our patients. Integration of use of guidelines to formulate a checklist for reporting, and also we have to make critical decision to support patient management. So this was all standard guidelines routinely coming up, which we were also following. They were all a kind of banners, stickers placed everywhere in the department to follow these guidelines. This kind of plan was made for the entire hospital, and we had 2 3 new forms generated to fill up by the patient, by the relatives. We did not want many people to accompany the patient during the COVID times. Even now, the waiting area was transformed. The chairs which were there in the waiting area, they were removed, so that we can avoid crowding as much as possible. Those patients who can come alone, they were asked to come alone, do their scan. The films and CDs, they were given immediately after the scan, so that they do not need to come back again for the reports. And we used to mail them the report, and that is what we are continuing now as well. So a lot of guidelines came in from international societies, national societies, and it was well established that CT scan is something which is really critical for these patients. So there were all steps to flatten the curve, effective triaging, screening, services offered only to emergencies and semi-emergencies, but later on everything had to be open, because as we all know, patients can wait for a limited time duration, but they cannot wait till endless times, because they are also non-COVID diseases, and we need to address them. So we had formulated the protocols for imaging department, the entire team of consultants at radiology, with team of consultants at other chain of hospitals in our unit of Nanavati, like the Max Hospital. So we all used to have a combined discussion and create standardized protocols of cleaning the machine, wrapping the machine, of handling these patients, how many personals will be there while the patient is in the department. We used to keep it at the minimum, so only one, maybe one person in full PP to position, and one technician to scan. Doctors used to be outside, no receptionist, and the doctor used to report it from a remote access. After that, a thorough cleaning was done for the machine and the gantry and the room. Then we used to wait. Even that period of waiting was not very well defined, but we used to wait for almost an hour before taking the next patient. So we had formulated flowchart kind of like this, and we used to revise it with our all these staff members, because for a radiologist, for resident doctors, technicians, it used to be easy. But for those staffs who are just like the cleaning staff or the lower staff, they might not understand the importance of all these. So we did a lot of training. So we had our own admin of the imaging department, Kaustubh, who did a lot of training with these personnels to ensure that what we are making is being followed at the ground level. So something like this, a 3D depiction for CT, for MRI was made to make them clearly understand that, see, the patient will enter from this side, it will be scanned, and the patient will go out from the back door. Nobody should be there in that intervening area. So initially it was difficult, but it just took, say, maybe 1 week, and everybody was well trained. And this thing is still being followed at our department, though the timings we have slotted it down. It's not like every time we do COVID scan, so we have kept one slot. We just have one machine as a CT scanner, so we kind of compartmentalize and do the scans. Ultrasounds are also being done with precautions, because ultrasound, the radiologist is in very close contact with patient, so it again becomes a high risk. And portable ultrasounds also were required in COVID ward itself. So the a person, the doctor who used to go for ultrasound or who is going right now, also a lot of precautions are being taken. Strict disinfection protocols are being followed till date. So we are taking, and all of us, I'm sure, are taking the best of the precautions and preventions to safeguard ourselves, our staff, and our patients. Code white, we used to do MRI based stroke protocols, but MRI, preparing the MRI department used to take a longer time, covering the machine and various other factors. Even the scan itself was around 15 minutes, and the exposure was expected to be more. So we changed it to city based protocols in our department. We always try to be in touch with whatever changing protocols and guidelines are, so that we can be updated and we don't miss upon anything which is important as far as the protection of staff and patients was concerned. CT became the cornerstone, and we know that till now there are various studies of with meta-analysis of over 10,000 patients, where they say that yes, CT is the way to go ahead, because CT scans can triage and also can quantify the degree of infection, and also can be used to follow up these patients for sequelae of COVID infection. So standard findings in CT scans, which we all know, are the bilateral peripheral basal dependent ground glass opacity. So we made a kind of a standardized reporting template for our resident doctors, for our even for our final reports, so that we just have to put the important findings and grade the COVID related findings on a CT of the lung and chest. There were some atypical findings as well, which we saw, which we even published. So, like not typical, but yes, lymphadenopathy, cavitation, pneumothorax, also pneumomediastinum like findings also we all saw during this time. So, CT played a very, very important role. It was a quick scan for all elective procedures. We were doing CT scan prior to admitting the patient, and also to understand whether this patient is suspicious, and accordingly was shifted to the concerned ward. So for suspected cases, RT-PCR negative cases with SARI, equivocal chest X-ray patterns, molecular diagnostics whenever not possible, emergency surgeries, high aerosol generating procedures, there were high recommendations for the CT scan. So this was the reporting template kind of thing which we also made, and we gave CORAD scoring. Very soon the physician counterparts at our hospital, they were very well versed with the CORAD's scoring system and the CT scoring system. So they also could understand what we meant by saying CORAD's 4, 5, and by quantifying the disease burden. We also resorted to the teleradiology and remote access services and AI as well. We also took help of an AI-based software to triage our X-rays, because X-rays were tremendous and numerous. And we kind of triage them to high suspicious, low suspicious, and normal X-rays, so that we can give them rapid feedback on after these scans to our referring physicians. So definitely this was a time when we understood the importance of the technology and the flexibility which technology can give it to us. With remote access, we were 24/7 available during the scan times and otherwise to report the scans, and at the same time we were ensuring the safety of our radiologists and residents. Even the Indian radiologic societies, they played very important and dynamic roles. Like, most importantly to name is Indian Radiological and Imaging Association, IRI, and also the other national societies. They provided and came up with standardized guidelines. They came up with lot of resources where you can refer to and get yourself corrected if you want to kind of standardize your protocols. And IRIA took special measures with ICRI to continue education. So all these times, all these difficult times, free webinars, almost over 150 now, were arranged, and it was freely available to all the members, non-members of the IRIA, and these were being attended by resident doctors, by consultants, and everybody was learning even during these difficult times. Exam formats were changed because it was not possible for people to actually go and give exams. So just to save their time, their year, exam formats were changed. IRI also took efforts to look into the mental and social well-being. A lot of other initiatives like Dear Zindagi, it was kind of a didactic session with a psychiatrist, how to handle these difficult, stressful times. So all these measures were taken to help the radiologist cope up with the ongoing changes. What are the key things we learned from the past? If just to say one, it will be that the humans or the people around us are the most valuable resource, and we should take all the efforts to safeguard our staff and our colleagues and our own self. Key things what we learned are: ensure rapid sharing of accurate and useful information, ensure infection prevention protocols are up to date, create new hybrid multitasking working team, enhance teleradiology services, and manage emotions during the adversity. There will definitely be long term impacts on the radiology workflow. So, there might be various ways we can respond to what is happening around us, but we should also look towards securing liquidity, ensuring access to capitals, and engage with policymakers, specifically when we are talking about standalone centers and smaller units, because there is definitely going to be a economic burden to the society and to the healthcare as well. So as we all know that already the industry is coming up with a lot of new solutions to what the impact is all about, and even the government measures are helping us to cope up with these crises. But all of us are moving towards unlocking and the new normal. OPD services have resumed, and as they resume, the normal patient load slowly comes back to the pre COVID time format. Screening protocols strengthened, social distancing norms are still being followed and are required. Strict disinfection protocols need to be continued. We should not think that yes, cases are coming down, so we can just be a more lenient, but we should not do that. And that continuation of separation of these COVID, non COVID patients still continues. So we are trying to resume care for all the non urgent scans and patients as well. We are strengthening our screening protocols, and even in our department at every level, we are following the COVID related protection and prevention protocols. So slowly we are seeing a trend where we saw that April, May, the patient footfall was very less, it was going down. But August, September, it's slowly coming back to the pre-COVID numbers. So we as radiologists again have the responsibility, as we have to continue working the way we were, but with all these valid preventions and precautions, and at the same time ensure safety of our staff. We actually are looking forward to newer solutions for these new problems with the help of technology, AI, teleradiology, so that with minimum human resource engagement, we can give the best outcome and best of the reports. Patient testimonials are really important because they uplift the psyche of the persons or the personals who are working for these COVID patients in the difficult time. So when patients give us positive feedback, it really boosts the morale of the department of the workers. So try taking these testimonials whenever possible from the satisfied patients, their relatives, and these bring positive vibes in the difficult times. So, coming to conclusion, and I would say that we have, as human race, won over several adversities in the past, and optimism is this critical situation. In this critical situation, will give us immense inner strength. So, scientists and researchers, as we all know, are working all over, and they are bringing best of their efforts to get an efficient vaccine and drugs toward the pandemic and controlling this COVID-19 infection. So we should till then do our best by contributing and following these safety norms and dynamically being ready to face the challenge with as safety measures as possible in place. So, with this, I would like to conclude and continue with your learning, continue with your routine practices, and get adjusted to the new normal. Stay safe. Thank you all.
Thanks a lot, Dr. Mitusha Verma, consultant radiologist Nanavati specialty, super specialty hospital, for your talk on impact of COVID-19 on radiology practice. It was a very good insight and good PowerPoint presentation. Thanks a lot for it. Thank you.